Now we're going to see the aortic aneurysm. The aortic aneurysm could be in the ascending aorta or in the descending aorta. If it is in the ascending aorta or the thoracic aorta, we usually think in Marfan syndrome or some disease of the collagen or connective tissue. And if it is in the descending artery, we think because of atherosclerosis. In Marfan syndrome, we have this cystic degeneration or cystic medial degeneration. This is fragmentation of the elastic tissue in the vasa vasorum and necrosis of the medial layer in a background of mucopolysaccharides. This weakens the wall of the vessel and predisposes. Here could be to aneurysm, but in other parts of the aorta, to dissection of the aorta. In ascending aorta, we also have the tertiary syphilis complication of the heart. This is, we have endarteritis of the vasa vasorum. So we obliterate the lumen of the vasa vasorum. We also have plasma cells and granuloma cells. But the issue is that the lumen is obliterated, and so we weaken the vessel wall because we are obliterating the vessels that provide the wall of the great vessel with blood. So if the wall of the vessel do not have blood supply, it's going to get weakened. So this is for syphilic thoracic aneurysm. That here is the left ventricle, here is the aorta. The valve, if we have here the aneurysm exactly in the root of the valve or the root of the aorta, the aortic valve can get regurgitant or have insufficiency because we are expanding the root. So the patient can have symptoms of regurgitation of the valve. This is usually because of atherosclerosis, and in this aneurysm we have this ballooning dilatation. It looks like a tree. They say appearance of tree bark. In the abdomen, if the aneurysm rupture, we have a triad that is hypotension, flank pain, and pulsatile abdominal mass. And this is the triad. Usually we see it in male, smoker males. Could be also with hypertension, but the most important factor is smoking and the gender. And the smoking dictates the severity of the aneurysm, the degree of dilatation, and so the reparation, if it could be surgical corrective or no. If the aneurysm, the abdominal aneurysm is greater than 5.5 centimeters, and or the aneurysm of the aorta is greater than 6, we do surgery. We correct it chirurgically. Also, even though it is less, the units are less, is less than 5.5 for the abdomen or less than 6 for the abdomen. If we have that the aneurysm is rapidly growing, we also should do surgery. The screening test is every people that is over 65 years of age, we should do one lifetime screening of the abdominal aorta, and if we see it completely normal, we don't need for their evaluation, nor for their screening. But if we see an aneurysm, we should following it, and if we see that it's rapidly growing, so surgery is indicated. And when we suspect this, we do an ultrasound, and usually the diagnosis is the ultrasound. We can do other imaging studies, but for help to localize exactly the anatomical region, like the catheterization or something like that. But the diagnosis is with ultrasound. In the aneurysm, we have inflammatory cells that have been replaced with fibroblasts, macrophages, and fibrous tissue that thicken the intimal layer and thins the wall of the vessel. So we have the dilation of the vessel because it is weakened, so it dilates. And complications are, here we have a laminar flow, here, and now it is turbulent. So in turbulence we have it's part of the Bishop triad of hypercoagulable states, endothelial damage, and abnormalities in the flow. Here the abnormalities are turbulence, not anastasis. So we can have thrombosis. The thrombosis could be because of this turbulence, or also because stasis here. And in the embolism, this is the lodge of the or a part of the thromboembolism in some other part of the body. We can also have a fistula. And well, these are the complications. The treatment is correct chirurgically if it is more than 5.5 or greater than 6, or if it is growing very rapidly. Usually the aneurysm is in the abdominal aneurysm is below the renal arteries but before the bifurcation of the aorta. And also we can have symptoms of compression, the same as in dissecting aneurysm. In dissecting aneurysm we also have symptoms of compression. Could be asymmetric pulses of the limb. It could be deepening of the voice, cough, etc.